Hello, everyone. Welcome to our session today. I am Megan Cruz, a breast medical oncologist from Cleveland Clinic, joined by Erin Downs-Kelly, who is the Director of Breast Pathology here at Cleveland Clinic. And we will be talking to you today about HER2 and breast cancer, testing guidelines, and new treatment approaches. Here are our disclosures. And our session today is funded by an independent educational grant from Daiichi Sankyo Incorporated. Here are the objectives for our talk today. We will first apply key concepts from the ASCO-CAP 2018 Focus Update on HER2 testing in breast cancer. We will summarize some recent clinical advances in the medical management of patients with HER2-positive breast cancer. And we will describe the science and emerging evidence around diagnosis and treatment of HER2-low breast cancer. So to set the stage, I wanted to talk a little bit about HER2 itself. This is a 185 kilodalton membrane protein expressed in normal secretory epithelial cells. Of specific interest for our conversation today is the expression in breast tissues, but it is also expressed in pancreas, intestine, and salivary gland tissue. The ERBB family of tyrosine kinases are transmembrane proteins that regulate cell growth and proliferation, as well as adhesion and migration. They consist of an extracellular binding domain, a transmembrane lipophilic segment, and an intracellular tyrosine kinase domain, except for HER3, which does not have this intracellular tyrosine kinase domain. The family of proteins actually induces changes in the cell and cell signaling with ligand binding and then activation of tyrosine kinase domains by either homodimerization or heterodimerization. And actually receptor overexpression or mutation can also induce this dimerization and activation. And many of the medications that we will talk about that HER2 target different aspects of this tyrosine kinase itself. HER2 is both a prognostic and a predictive marker. So when it comes to prognosis, when we find it overexpressed or amplified, it's associated with aggressive tumors that have an increased incidence of metastasis and worse clinical outcome compared to those tumors that are HER2 negative or non-amplified. And it's important to note that that worst clinical outcome is actually in the absence of appropriate therapy. Now that we have excellent HER2 targeted therapy that is used in combination with chemotherapy, the clinical outcomes for these patients are excellent and actually on par with the prognostic expectations for patients that are HER2 negative. In terms of predictive implications, we know that patients who are HER2 positive or amplified have greater likelihood of responding to HER2 targeted therapies and also to chemotherapy, even on its own, in the absence of HER2 targeted therapy. To give you an idea about how treatment for HER2 positive breast cancer has evolved over time, this marker was initially found in the 1980s by Dennis Slayman in his lab, and they found that HER2 gene amplification was associated with these worse clinical outcomes and thus an unmet need in the breast cancer population that we could improve treatment for. In the 1990s, trastuzumab was first introduced in clinical trials for patients who had metastatic breast cancer that had progressed on standard chemotherapy. There was actually a large benefit in survival for patients treated with trastuzumab-containing regimens, and this medication was approved by the FDA for metastatic disease in 1998 and has since become the cornerstone of care for these patients. In the 2000s, trastuzumab was moved up in the treatment of patients with HER2-positive breast cancer, such that we started looking at it in combination with chemotherapy for patient receiving curative intent treatment. And here it also had a very large impact on cure rates and survival, and thus it was approved by the FDA for early stage disease in 2006. Although trastuzumab-based regimens work very, very well, and many patients are cured because of these drugs, ultimately about 30% of patients treated for early stage curative intent HER2-positive breast cancer do relapse with metastatic disease. And this is a particular concern as HER2-positive disease has a predilection to go to the brain. And when HER2-positive disease is in the CNS, it is often very difficult to treat. And we treat many of these patients in the neoadjuvant or pre-surgical setting, where we're able to see the pathologic response to therapy. And even those patients who obtain an excellent response or a pathologic complete response, those patients also still have a 10 to 15% recurrence rate with metastatic disease. So even among our best responders, we still worry about long-term relapse risk. And this happens because the cancer cells are able to develop pharmacologic resistance to our current HER2-directed therapies, and thus new drug development is focused on circumventing these paths of resistance. So here's a figure that gives you an idea of what our current HER2-targeted therapies are. I've circled those therapies which are FDA approved in the red circles. So you can see trastuzumab here, the monoclonal antibody that we've been talking about that binds to the extracellular domain of HER2. There's also pertuzumab, which is a newer generation monoclonal antibody binding to a different site on HER2 and preventing heterodimerization. We have drugs called antibody-drug conjugates that are formed with the basis of trastuzumab as the monoclonal antibody with cytotoxic chemotherapy attached. And one example of this is TDM1, which we'll talk about more later in the presentation. The way that these drugs work is the antibody targets the entire molecule to HER2. The molecule gets endocytosed into the cell, and once in the cell, the antibody and then the cytotoxic chemotherapy, indicated by the orange circle here, dissociate, and thus the chemotherapy is then free to have its impact inside the cell. TDM1 was the first of these drugs approved for breast cancer, and we now have a newer drug, trastuzumab deruxtecan, that is also an antibody-drug conjugate, and I'll get into the details of that a little bit later in the presentation. The last class of drugs that we use in the HER2-targeted space are actually the tyrosine kinase inhibitors, which are small molecules and have their impact intracellularly. These include lapatinib and neratinib, as indicated by the red circle, and also a newer drug called tucatinib, which is more specific for HER2 itself, with less effect on the rest of the ERBB family. And with that background, we'll move into the pathology portion of our presentation.
So thank you. So we've seen these expanded therapeutic options for HER2 positive, so it's really important for laboratorians to be able to identify who is actually HER2 positive and therefore what patients are most likely to derive a benefit from this targeted therapy. So it kind of depends on what our definition of HER2 positive is. And I would say that over the years, this has been somewhat of a moving target. So it depends on what year we're asking. We've had ASCOICAP guidelines in place since 2007, and there have been small changes with every update in trying to better define who is HER2 positive. And also it depends on which methodology we're actually using to assay for HER2. So, excuse me, we do have some testing issues in HER2, and if we look historically, really for the first decade of HER2 testing, there were no guidelines. So we really didn't have a guideline for standardization of our pre-analytical factors. We weren't talking about what fixative to use. We weren't talking about our length of fixation or cold ischemia time. And then we didn't have guidelines as far as interpretation and reporting. So there was some interlaboratory variation in how things were reported. And that was really brought out in this intergroup trial that was looking at patients who were deemed locally to be HER2 positive, either through overexpression or amplification. So deemed to be positive at a local laboratory, Patients were then going to be randomized to receive either chemotherapy or chemotherapy with trastuzumab. And then these locally positive patients had undergone confirmatory central testing. So they were going to use either a HERCEP test, immunohistochemistry, or VISIS PathVision FISH centrally to confirm the status. So out of the first 119 patients enrolled that were centrally tested, 67% of the specimens submitted by local laboratories were confirmed to be FISH amplified by central testing. And there was only 74% concordance between central and local HERCEP test results. So this is a paper from 18 years ago that really pointed out there's some inter-laboratory variation. And this could have been due to multiple factors. It could have been due to how the tissue was handled pre-analytically. It could have been due to which assay was actually being performed, meaning which antibody was used for immunohistochemistry. So the issues in testing really brought about the idea that there should be guidelines, and ASCOICAP came up with recommendations for HER2 testing in breast cancer. And the idea was to really improve the accuracy of HER2 testing and develop algorithms which would basically tell laboratorians how we should be handling the specimen, when we should exclude an assay, and then what reporting criteria we should use, and how positive, equivocal, and negative values should actually be defined. So the first guideline recommendation was in 2007, followed by an update in 2013, and then a more focused update in 2018, which we're working with these days. So there are two methodologies to detect HER2. We can either use immunohistochemistry, and there are several FDA-approved antibodies, or we can use some sort of in situ hybridization. It can either be FISH or fluorescence in situ hybridization, or we can do a bright field in situ hybridization. So it's the idea is that we need to test all newly diagnosed invasive breast carcinomas, and we also need to be able to test patients who have metastatic disease, especially if that tissue is available. These are who we should be testing. We know some of the variables in HER2 testing can be related to how the tissue is handled in the pre-analytical phase. So what fixative was the tissue? What fixative was used in the tissue? How long was the tissue actually fixed in that fixative? And our analytical issues can include everything from which assay are we using and how did we validate that assay, to antigen retrieval and the reagents that we're using. And then our post-analytical variables include the interpretation criteria that we're using, as well as we have a lab that's participating in proficiency testing. So in 2013 and 2018, the ASCOICAP guidelines really honed in on tissue handling and kind of minimizing deleterious effects of cold ischemia time. So we really try to have tissue basically less than an hour of cold ischemia time, meaning time from removal from the body and cessation of blood flow to submersion in an appropriate amount of neutral buffered formalin, because that is the fixative we need to be using. We need to use 10% neutral buffered formalin. We know that fixatives other than neutral buffered formalin have shown really inconsistent results, usually meaning we get false negative results in tissues, with fixatives other than neutral buffered formalin. We know that we should be fixing our tissue for a minimum of 6 hours and not longer than 72 hours, because again, falling outside of that time frame of fixation can lead to erroneous results. This is so important that we actually need to be documenting these fixation time points in either the accession or in the pathology report itself. And we need to be making sure that we have validated protocols in our laboratory. And labs need to show 95% concordance with an already validated test. So first, let's talk about immunohistochemistry. As Dr. Cruz already mentioned, HER2 protein is a transmembrane tyrosine kinase, and we can use immunohistochemistry to detect the expression, and in the case of HER2 positive cases, overexpression of this protein. And the results are evaluated as an intensity of membrane staining and what percentage of our malignant cells have this membrane staining. So there are two scores for negative, IHC0 and IHC1+. Negative is no staining, sorry, 0 is no staining or incomplete staining that is faint and really barely perceptible in less than 10% of tumor cells. A 1+ score is incomplete membrane staining that is faint or barely perceptible in greater than 10% of tumor cells. Whereas if we're going to call something equivocal or 2+, we should be seeing weak to moderate complete membrane staining in greater than 10% of tumor cells. And to be considered HER2 positive by immunohistochemistry, we need to see circumferential, complete, and intense membrane staining in greater than 10% of tumor cells. Here are different examples of our scores, and you can see on the left we have no membrane staining. Under our 1+, we have this faint and barely perceptible membrane staining that's very weak and non-circumferential. Our equivocal, we can see just a greater intensity of our membrane staining and in a higher percentage of our cells. And then our 3+ on the far right panel, where we see this very intense membrane staining in what looks to be about 95% of these tumor cells. So a nice strong 3+. There are some immunohistochemical staining patterns that we need to be aware of, and morphology matters. So this is an example of a micropapillary carcinoma where we see these morula-like clusters surrounded by this cleft. And what's important to know about micropapillary pattern is that they can have basolateral staining, but it might not be circumferential. So here we see pretty intense basolateral membrane staining, but it's not circumferential, and there's no way that we could ever call this 3+ because it's not circumferential. So the guidelines actually state that we should consider calling these equivocal and reflexing them to FISH, because there is a small percentage of cases that have this pattern of immunohistochemistry that actually may be FISH amplified. The other pattern to be wary of is that we can have really intense circumferential membrane staining, but it's going to be in less than 10% of tumor cells. Again, an unusual pattern, unusual scenario, but consider calling it equivocal and then doing additional testing. And that additional testing includes, we can use the same specimen and use an alternative test like some sort of in situ hybridization assay, or we can actually, if we have additional tissue available, use a new specimen, and we could either use the same test or use an alternative test. So there's some pros and cons associated with immunohistochemistry. The pros are that it's relatively inexpensive and easy to perform. It's readily adaptable to most laboratories because most laboratories have immunohistochemistry up and running already. Bright field microscopy is something that's very common to pathologists, so there's a comfort level with that. And we can really evaluate the context of our results in the histomorphology and how they relate. And these slides have some permanence. We can store these immunohistochemical slides, and the stain typically doesn't fade. The cons are that our pre-analytical variables, like our cold ischemia time and type of fixative, can really affect these results. We know that there are also, unfortunately, some discrepancies in pathologist interpretation. This is still a subjective interpretation, even though we have recommendations which to follow and help us score these. So our second method to which detect HER2 is in situ hybridization, and specifically I'm going to talk about fluorescence in situ hybridization, where we have fluorescent probes that bind to nucleic acid sequences, and they really do this with a high degree of complementarity. There are several FDA-approved assays. There's even a single probe assay, and we're just going to look for HER2 copy number with that. And there are dual probe assays where we assess HER2 copy number, and then we have a second probe that would hybridize to a reference point. Most commonly, it's a centromere enumeration probe or a SUP17 probe. So then you can calculate a ratio of HER2 over SUP17 and calculate that ratio. And really, the dual probe assays are preferred by ASCOICAP guidelines. So when we talk about our update in 2018 guidelines, there are 5 in situ hybridization groups. ISH group 1 is positive. It's an invasive cancer that has a HER2 average copy number per cell of greater than or equal to 4 and a HER2 sub-17 ratio of greater than 2. So that's the classic amplified. And an ISH group 5 is a non-amplified. So these are HER2 copy number per cell of less than 4 and a ratio of less than 2. And just examples of what clear-cut non-amplified and clear-cut amplified case look like. Here we have our sub-17 in green, which is our enumeration probe. HER2 probe is in red, and we can see in this cell we would have a ratio of HER2 to sub-17 of 1 because we have 2 copies of each. Contrast that with our cell here on the right, and we can see we have multiple copies, probably greater than 20 copies of the HER2 probe here. We have 3 copies of our sub-17, so about a ratio of 6 in this cell. So this is a nice HER2 amplified case. So some of the pros and cons of FISH are that it's pretty objective. That's a real advantage. And it's thought that some of the pre-analytical factors have less of an impact because we know that DNA can sometimes be more stable than protein. Some of the disadvantages are that it's actually time consuming and it requires more expensive equipment. You have to have a fluorescent microscope and you have to have staff who know how to perform the assay and score it. Another disadvantage is that this assay result lacks permanence because our signals fade over time. The fluorescence just diminishes and it makes it difficult to go back and read a case if you need to. There's also greater potential to miss intratumoral heterogeneity, so you really need to look at the entire tumor and make sure we're not missing an area of amplification that's not diffuse throughout the tumor. And also morphology can be pretty challenging under a fluorescent scope, so we have to make sure that we're counting the correct areas. So these uncommon ISH signal patterns that were really addressed in the 2018 focus update, and these fall into groups 2 through 4, and these are defined using a dual probe assay. So ISH group 2 has a HER2 sub-17 ratio that's greater than 2, so they look like they're amplified just based on ratio, but their average HER2 copy number is less than 4 signals per cell. Then there's an ISH group 3, which we have a ratio that's less than 2, but an average HER2 copy number that's greater than 6. And then ISH group 4, where again we have a ratio that's less than 2, but we have an average HER2 copy number that's greater than 4 and less than 6. Here we have some examples of what these look like under the fluorescent microscope, where here we have an ISH group 4 where we have 5 copies of our HER2 here, but we also have increased copy number of our sub-17. So we're not going to get to an amplified number here. So we'll have a ratio that's less than 2. And as you look around this cell, we never see greater than 6 copies of HER2 per cell. So in ISH group 4, contrast that with an ISH group 3 over here, where we can count and see there's about 7 HER2 signals in this cell. So there are multiple cells here that have HER2 copy numbers ranging from 6 to 7. And at the same time, we have increased sub-17 signal. So again, the ratio here is never going to be greater than 2, but our copy number is greater than 6. And then here is our ISH group 2, where we have more or less just 2 or 3 copies of our HER2 signal per cell, but we only have 1 centromeric enumeration probe basically per cell. So because our denominator is less, our ratio is going to be higher in this. So in this, if we just look at the ratio, it looks like it's greater than 2. So to resolve these ISH patterns, it requires immunohistochemical correlation. That's really what came out of the 2018 update. You have to have IHC review for these dual probe ISH patterns, groups 2 through 4. To really arrive at our most accurate HER2 status designation as either positive or negative. So it's a combined result. So why did we get to this point in this latest update? Well, this was a group of large trials that have looked at HER2 positive patients and outcome, these BCIRG trials. So basically they assigned, looking at across these trials, they've looked at 10,468 patients, and they were assigned these 5 different ISH groups by the 2013 guidelines. So if we look at just what we think of as classically amplified, a ratio that's greater than 2 and an average HER2 copy number greater than 4, these patients had 3+ immunohistochemistry, and they had improved disease-free survival and overall survival when they were treated with trastuzumab. So then we look at a much smaller population of patients, and these are the patients who are in that group 2. They have a ratio that's greater than or equal to 2, but an average HER2 copy number of less than 4. So when we look at these by immunohistochemistry, they correlate usually with a 0 or 1+ immunohistochemistry. And although this group was very small, they did not see improved disease-free survival or overall survival when treated with trastuzumab. So then we move on to our group 3, where we see these patients who have a ratio that's less than 2 and an average HER2 that's greater or equal to 6 in copy number. And these patients have a worse disease-free survival and overall survival than the non-amplified group. Remember, in the original trials, these patients would not have been treated because they did not have, a ratio that was greater than 2. So the number here is really pretty limited for analysis. Then another smaller group, about 4.1% of that total population, falls into this group where we have a ratio that's less than 2 and an average HER2 copy number that's greater than 4 and less than 6. These patients' immunohistochemistry correlated to be 0 or 1+. These patients did not get trastuzumab, and they actually had outcomes that were very similar to the non-amplified group. And then the largest group here is our very classic non-amplified patients, where there's a ratio that's less than 2 and an average HER2 copy number that's less than 4. And these also correlated with 0 or 1+ immunohistochemistry. So really, what we're really focusing on in the ASCO-CAP guidelines are these groups 2, 3, and 4. 1 is our classic amplified, group 5 is our non-amplified, and then these groups, you have to use immunohistochemistry to define them. So what do we know about group 2? These are those patients that had a ratio that was greater than 2, but a copy number that less than 4. We know these are typically ER positive. Again, they're usually 0 or 1+ by immunohistochemistry for HER2. And again, based on limited data, they did not receive benefit from treatment with trastuzumab. So if we have a group 2 a group 2-ish result, and we correlate it with our immunohistochemistry that's 0, 1+, or 2+, ASCO-CAP guidelines suggest we call this negative with comment. And basically the comment admits that the efficacy of HER2 targeted therapy in this really small subset of cases did not show improved survival in this group, even though they were included because originally in those trials because they had an amplified ratio. So if the immunohistochemistry expression really should complement this, and if the result is not 3+ by immunohistochemistry, then it's recommended that we basically call them HER2 negative because of their low HER2 copy number and lack of protein overexpression. So then what about group 3? Well, these are more heterogeneous tumors. They may be ER positive or ER negative. They also may be HER2 positive by immunohistochemistry or HER2 negative by immunohistochemistry, so heterogeneous on multiple fronts. And there's really no good outcome data on these patients because they were not included in those original trials because their ratio was less than 2. So if we have a group 3-ish result, if immunohistochemistry is 0 or 1+, then we basically call them negative with a comment again. There's insufficient data in these cases to really recommend treatment with HER2 targeting therapy. If immunohistochemistry is 2+, then we need to count an additional 20 cells by a different observer. And if we get the same result, then we can call this HER2 positive as a combined score. So we have an ISH that's a group 3 and an IHC that's 2+, and we can call it HER2 positive. If we have this ISH group 3 and we do immunohistochemistry and it's 3+, then our result is just HER2 positive. So the last group is the group 4, and typically these tumors are ER positive. Again, They're usually 0 or 1 plus by HER2 immunohistochemistry. And even though they weren't included in the initial HER2 trials because their ratio is less than 2, their outcomes are similar to patients who are basically HER2 negative and those who did not receive trastuzumab. So if we have a group 4-ish and our corresponding IHC is 0, 1 plus, or 2 plus, again, the comment is that these are negative with comment, and it's just explained that in the absence of protein overexpression, it's really uncertain whether these patients are going to derive benefit. So it's suggested that they be considered HER2 negative. One other aspect of testing that's important is heterogeneity. And there's in the update, there's the aspect of HER2 heterogeneity, how it relates to in situ hybridization is described in the supplemental data. And basically, any aggregate population of amplified cells that comprises greater than 10% of the total tumor cell population should be separately counted. So you need to count both an area of unamplified and amplified cells, and then you're going to calculate your ratio for both of those areas. We should be reporting what percentage of the total tumor population has amplification, and then we call these cases positive for HER2. And again, explaining how the heterogeneity is present in reporting both amplified and non-amplified subsets. So that's why it's important to be able to scan an entire slide by in situ hybridization to make sure that we're not missing heterogeneity. Because we do know a little bit about heterogeneous tumors. We know that they're associated with a larger size. Frequently, they have a higher histologic grade and a greater frequency of lymph node metastases. And patients with HER2 heterogeneity seem to be less responsive to anti-HER2 targeted therapy because we see lower rates of pathologic complete response when following neoadjuvant therapy with HER2 targeted regimens. This is just an example of a high-grade tumor where we see sheets of these cohesive epithelial cells. We can appreciate how large they are in comparison to a stromal lymphocyte and how mitotically active this process is. So you can see here on the left-hand portion of this core needle biopsy of that tumor, if we were to just get this portion, we would call this HER2 negative. There's essentially no membrane staining in any of this tumor, whereas on the right-hand panel, we can see there's this diffuse and circumferential membrane staining that's present in greater than 10%. So this is a positive tumor. It's just very heterogeneous when we look at it by immunohistochemistry. And you can even see areas that you would score this as a 2+, and you would score this area as a 3+. So just to point out the heterogeneity that we can see in some of these tumors. So with that, I'll turn it back over to you.
Thank you. So I just wanted to show you some data on our new medical management strategies for HER2 positive breast cancer because things have come a long way. And some of these new treatments rely on the data that Dr. Downs-Kelly presented in terms of definitions of HER2 amplification as well as a HER2 low status. So in case 1, we'll be talking about a 59-year-old patient of mine who presented with a right breast mass that was 3.7 centimeters on ultrasound. She was clinically node negative at the time of presentation. A core needle biopsy of her breast mass was done, which showed invasive ductal carcinoma with invasive micropapillary features. And this was ER negative, PR negative, and HER2 positive with an IHC of 3+. And you can see here on the slide that we have examples from that core biopsy, as well as the HER2 IHC for the specimen. She received chemotherapy with a pretty standard regimen of 2 cytotoxic drugs as well as 2 HER2 targeted agents, trastuzumab and pertuzumab, and then underwent a right mastectomy with axillary lymph node dissection that actually showed quite a bit of residual disease in both the breast and the axillary nodes. So we staged her as a T2N1A tumor after her neoadjuvant therapy, and we were very concerned about this result. And I just wanted to show you why we get so worried when patients do not have a pathologic complete response after neoadjuvant chemotherapy. And that concern really comes from this data from the Cortazar group that was presented at the San Antonio Breast Cancer Symposium in 2012 and subsequently published. These are the results for HER2 positive breast cancer treated with neoadjuvant therapy. And what you can see here is that for the entire group of HER2 positive patients, those who attained a pathologic complete response after receiving neoadjuvant therapy had a much better event-free survival compared to those who did not have a pathologic complete response. And this trend was consistent across those who were both hormone receptor positive and those who were hormone receptor negative. So in a patient like mine, it really reflects this last panel of the curve here with a very poor event-free survival going out to 5 or 6 years without the pathologic complete response. So prior to the last couple of years, we would say, well, we acknowledge that this is the case. There's really nothing else we can do differently about it. But because this was a large clinical unmet need in our patient population, a large trial was designed to look at this question. And that is the Catherine study, or NSABP B50, which took patients who had residual disease after neoadjuvant therapy for HER2 positive breast cancer and randomized them to either standard therapy with a year of trastuzumab or a year's worth of TDM1, that antibody drug conjugate that I mentioned earlier. So basically, a year of antibody therapy or a year of antibody plus more chemotherapy. And it turns out that the patients who received the adjuvant TDM1 compared to the adjuvant trastuzumab actually had much better invasive disease-free survival at 3 years after randomization. And that's reflected here in the curve on the left, where you can see the patients in the blue line had much better survival than the patients in the red line. This is actually about 11% improvement in invasive disease-free survival at 3 years, which is quite large. The invasive disease events that occurred actually spanned the spectrum from distant recurrence to local regional recurrence or contralateral breast cancers. The biggest difference here was actually reflected in the distant recurrences that occurred. One interesting thing that we'll talk about a little bit more is the fact that CNS recurrences seem to be about the same number in both groups, again, highlighting an unmet need and further work that needs to be done in this patient population. Which leads us into case 2. So this is a 50-year-old patient of mine with a history of stage 3 breast cancer that was ER/PR positive and HER2 positive, diagnosed in 2014. She actually received neoadjuvant chemotherapy with HER2 targeted therapy and had a pathologic complete response at the time of her surgical resection. She received standard radiation therapy as well as 5 years of endocrine therapy and completed all of that in 2019. Unfortunately, earlier this year, she presented to the ED with headaches, nausea, and vomiting, as well as dizziness, which had been occurring over a few weeks, and was found to have a large cerebellar tumor. This tumor was resected and showed ER-positive, HER2-positive metastatic disease, and there are some reflections of her pathology here on this slide for you to view. So in a patient like this, we thought we were in the clear because she had a pathologic complete response, but unfortunately she fell into that small population that does have a CNS recurrence after pathologic complete response. And so this trial, which was recently published earlier this year in 2020, known affectionately as the HER2 CLIMB study, sought to treat patients who had previously received standard HER2 positive targeted therapy and chemotherapy with a HER2 targeted TKI, tucatinib, in combination with both trastuzumab and capecitabine. So patients in this study had failed prior chemotherapy regimens and then were randomized to either the tucatinib containing arm or the standard of care arm. And what was interesting about this study is it actually allowed patients to enroll who had active brain metastases, not previously treated with either radiation or surgery, which was really a new concept and milestone in our breast cancer clinical trial development. And the results were quite amazing. So there was a large overall survival improvement with the tucatinib containing regimen. And I think what was most astounding is the fact that patients with brain metastases enrolled in the study had a 0% overall survival at 1 year with the standard of care arm, compared to a 25% 1-year survival in the tucatinib containing arm. So certainly for patients with HER2 positive brain mets, this has now become our new standard of care, and it was approved by the FDA earlier this year. And one final case for you. This is a 40-year-old premenopausal woman who was initially diagnosed with breast cancer in 2014. At that time, her cancer was ER positive, PR positive, and actually HER2 negative. So she received standard treatment, and you may be wondering, why did we bring up this case when it's actually not HER2 positive? But we wanted to comment here about HER2 low breast carcinoma. So I'll let Dr. Downs-Kelly tell you a little more about that.
Thanks. So there's really no formal definition of what a HER2 low breast carcinoma is in the laboratory. There have been trials that suggest a HER2 low breast carcinomas are going to be those that are 1 or 2 plus by immunohistochemistry and lack HER2 amplification. So if we apply this kind of across the board, then there's a high percentage of our breast carcinomas that are actually going to fall into this category of HER2 low. And it represents a spectrum of carcinomas that really have different kind of degrees of HER2 expression. And the studies have shown that these carcinomas have a poor prognosis as compared to just HER2 negative breast carcinomas. So those that are 0 by immunohistochemistry. We know that these are typically ER positive and are usually of the luminal B molecular subgroup by gene expression analysis. And they tend to have a higher histologic grade and a higher proliferation rates when compared to ER positive and HER2 negative tumors.
So I wanted to bring up use of trastuzumab in HER2 low breast cancer for a moment, because these were patients who may have been included in our original trastuzumab-based studies. And this has actually been looked at in a large international trial through the NSABP, where patients with HER2 IHC 1 plus or 2 plus were treated with chemotherapy plus trastuzumab or chemotherapy alone. And there was actually no difference in the survival outcomes or disease-related events for patients who received the trastuzumab-containing therapy. So based on this data, we do not include trastuzumab in our adjuvant regimens for patients with HER2 low disease. However, the concept has not died off, and we actually are looking at it again in the metastatic setting. So for the interest of time, I will tell you that the patient that I started talking to you about for this case was ultimately found to have metastatic disease early on. And she was treated with a variety of regimens, both endocrine-based and chemotherapy. However, ultimately had continued progression in her liver that was found to be ER positive, PR positive, and HER2 negative. And here's just an example of the HER2 testing on the most recent liver biopsy specimen. Because she really did not have any interesting standard of care options left, we had looked at clinical trials for her, and one interesting clinical trial came up with this drug, trastuzumab deruxtecan, or in HER2. So this is another antibody drug conjugate, as I mentioned earlier, which is based in trastuzumab, but has a cytotoxic agent attached to it by an enzyme cleavable linker. And what's important about this is when that drug is brought into a cancer cell, because that linker is cleavable, the chemotherapy is released both in that cell and to neighboring bystander cells. So the idea here is that the HER2 really targets the chemotherapy to the cancer cell, but it may also kill off cells nearby. And this is a remarkably active drug. Here is some data for the response rates for this drug when used in heavily pretreated HER2 positive breast cancer patients. Patients in this study had received a median of 6 prior therapies and actually had a response rate of over 60%, including 6 complete responses, which is really unheard of at this stage in a pretreated patient population. It's actually also been looked at in these HER2 low tumors. So here's some data reflecting those patients who had either HER2 IHC 2 plus or 1 plus, with very similar waterfall plots indicating a cancer response to the therapy in a group that we would not consider typically treating with HER2 targeted therapy. And so that initial phase 1 data led to the conception of the Destiny Breast 04 study, which takes metastatic breast cancer patients who are formally HER2 negative, but have IHC levels 1 plus or 2 plus, and treats them with either physician's choice chemotherapy or trastuzumab deruxtecan. This trial is actively accruing, nearing its accrual goal, and so we hope to have results within the next few years. And my patient is actually on this trial. She is now 46 years old. She's 6 years out from her initial metastatic diagnosis. She's received 4 prior therapies, and she's responding very well on trial to the trastuzumab deruxtecan. She's received 12 cycles of therapy, has had a partial response, and is tolerating the treatment very, very well. So with that, what have we learned over the last 20 years of HER2-positive breast cancer treatment? Really, that patients with HER2-positive disease must receive HER2-targeted therapy in order to have the best chance of cure. The introduction of these agents has really changed the natural history of disease, and it seems like these drugs are best used in the preoperative setting where we can see the response in vivo and then target the adjuvant setting for optimization of medical therapy if a less than complete response is obtained. Despite these excellent results in the early stage setting, recurrence is still a problem, even for patients who receive the best responses, and CNS recurrences are a particular issue. So novel combinations of all the different drugs that I mentioned to you today, and the inclusion of immunotherapy is really where our field is moving.
So what have we learned about HER2 testing through these different iterations of the ASCO-CAP guidelines? Well, we know that they've really been dynamic, and they've tried to encompass the relevant literature to make small changes in definitions so that we are really hopefully focusing and identifying those patients who are best going to respond to targeted treatment. With that, we thank you, and we really hope that this had provided some background and a framework for discussions around HER2 testing and breast cancer. And we tried to highlight the newer therapies that are pretty exciting and really holding promise for progressive disease.
Thank you.
Thank you.